So at this point, in order to proceed any further, it's necessary that the amendment attracts a minimum level of support. To that end, I would ask Mohammed if you have a seconder.
Yeah, I'd be grateful if somebody can second me formally, then we can have a debate. We had a lecture on transparency earlier on, and this is the opportunity when we can just view our opinions.
I hear no response, so that means the amendment will fall as it does not have a seconder. So I ask colleagues if you're happy to agree the recommendations on page 23 to note the Chief Officer's report. Agreed. Thank you very much. Thank you. I move to item 5.1, which is the risk appetite statement and strategic risk register on pages 33 through 48. And I invite Martin Allen to speak to this as you wish. Chair.
I'm Martin Allen. I'm Business Resilience and Communications Lead in the Senior Leadership Team. The IGB has before it revised versions of the Risk Appetite Statement and Strategic Risk Register. The draft strategic plan and the medium-term financial framework are on the agenda for today's meeting later on, and work has been undertaken to align the activities within the strategic plan and the medium-term financial framework to the 8 risks in the Strategic Risk Register. The strategic plan outlines the 8 strategic risks, along with narrative which explains how the strategic plan will help mitigate each of those risks. This is also detailed at Appendix B to this report. Firstly, in relation to the risk appetite statement, the IJB and senior leadership team members have considered this at various sessions in the early part of 2025, making suggestions and comments, and as a result, the revised version of the statement is attached at Appendix A to this report. One of the proposals arising from those sessions and consultation on the statement was the suggestion that the statement be included in the agendas of the IJB and its committees to allow members to refer to the statement when considering board and committee matters. In relation to the Strategic Risk Register, and as the CFO has mentioned earlier, and as is referenced in the medium-term financial framework, there are risks associated with the estimates in the framework, and the medium-term financial framework report has outlined 3 risk profiles in relation to the delivery of savings. The report, the MTFF report, outlines how those risks will be mitigated, including actions to address issues identified within project plans as they arise through the Budget Savings Oversight Group and through the senior leadership team, also ensuring adequate project document and resources put in place to deliver plans, and working closely with teams going through change to maintain their engagement. The current strategic risk register template has been in use since the start of the IJB and has been updated as per the government's requirements. The current template has grown in size over the last 9 years, and following discussion at the senior leadership team, it's proposed that a revised template be developed to help SLT members and specific risk owners to have a more focused register, which will allow them to see more clearly the current performance of the mitigations of the risks. The proposed new template also links to the risk appetite statement and its risk dimensions in a more coordinated way. The template is currently being worked on and will be presented to future meetings of the Risk Audit Performance Committee and the IJB, as well as being used by risk owners in the senior leadership team. It is also proposed that the more detailed template be used for the annual review of the strategic risks and risk appetite, which is held with IGB members. Attached as Appendix B to this report is a revised summary of the Strategic Risk Register, which is replicated in the strategic plan and referenced in the medium-term financial framework. I'm happy to take any questions. Thank you.
Thanks very much, Martin. And as always, thank you for making this so clear and easy to understand. It's really appreciated. I particularly welcome the very plain English and simple to follow list of risks and the IJB's tolerance for those, which I think makes it very clear to everyone where we sit in this. Are there any questions for Martin, please? Martin, the other Martin.
Yes, thank you, Chair. I'm noting the comments about fiscal risks, and that there is mention that level of risk reduces depending on the development of plans to deal with financial uncertainty. So that's really helpful to have that understanding of the potential for 100% and 50% delivery. So is it the case that risk is mitigated by our very careful design of the strategic plan, of reducing and working through the medium-term financial framework, so forth? Does that comment there reflect that if we continue to plan and coordinate resources and react efficiently, that we will be able to mitigate these risks, and therefore if we don't, we won't? I'll take if that makes sense.
Thank you, Councillor Gregg, and through you, Chair. I don't know whether Amy as CFO would like to come in at that point around, because the risk report is obviously, as we say, aligned to the MTFF and strategic plan reports, but I don't know if there's a specific answer that maybe Amy could come table with.
Yeah, thanks, Martin. I think that what we're saying with financial risk is if we stick to our plan and we deliver on our plan, we will mitigate that risk. So we reduce the level of risk. We still have that underlying financial risk, as Councillor Malik alluded to earlier, that we have to manage during the course of the year. But the main risk about the direction of travel and understanding what we need to do along that path is mitigated by the strength of the plan. And I think that would always be the case. So I think that's what the risk is suggesting that we manage. Is that kind of clear?
Yes, thank you. That's very encouraging to have that information, that the planning, very careful planning, the contingency planning, will help us to deal with risks and potential hazards, resource pressures, and so forth, and also address demand and need as it continues to arise. So thank you very much.
Richie, thanks.
Yeah, thanks. A comment and a question along the same lines as Martin. I think it's really helpful to have that more explicit reference to risk around finance and budget. And then I've got the MTFF and the strategic plan coming later. But just to reinforce the point from the earlier discussion today around the IGB being regularly updated and RAPC being regularly updated in terms of financial performances is really, really important. And that again helps us in terms of visibility and indeed any opportunity for interventions, if you like, in terms of making sure that we can strive to break even. That's it. That's just so important. So welcome that increased focus. The question is around about it's on page 46 at the bottom on premises. And I appreciate you might not be able to say an awful lot today, but any comment on where we're at with the current premises review would be really welcome. Or if need be, I'm kind of happy to get something after meet today, just in terms of progress on that, just where we're at. Thanks.
Thank you, Richie. I think Sandy might be able to answer that question.
Yeah, thank you through you, Chair. Thank you, Richie. Question. In summary, what we're doing, two main areas we're looking at the moment. One is here in Aberdeen Health Village, which is mainly about maximising the opportunities for full utilisation of the health village, potentially including 7-day working, which already exists with GMED and out-of-hours nursing. So that's one piece of work. The other piece of work really relates to 4 buildings that are relatively close together at the other end of town. We've got Forestville Health Centre, we've got Northfield Clinic, we've got Maastricht Clinic, and we've got Horizons, which is a joint venture with the council on ED Road. So looking at those 4, identify utilisation costs, and is there the potential that we move out of one of those buildings? Recognise we don't own any assets, so all this would be done with the NHS Guarantee of the council, potentially to try to do what we did last year and moved out of College Street down beside the train station and moved out partly out of Carden, but basically to save us money. So these 2 projects are separate but related. It's not possible, for example, that haven't agreed this, but let's say we decide to leave one of those clinics, some of those activities might come to here, but we're a long way from that point at the moment. But we have a broad ambition to leave 1 or 2 premises per year. If that's the kind of, if we're on track for that again this year. Does that help?
Yeah, for yourself, Chair, that's helpful. And just in terms of when might an update come back with a bit more detail on that, just for IGB?
They have to go through impact assessments through the senior leadership team. I should know the date, but if somebody tells me when's the sort of autumn IGB date?
The 30th of September, and then we've got the 2nd of December.
It's been, I'll challenge myself and say we'll be trying to get something back by the September meeting. That'll require a lot of work to be done, but I suspect December kind of see Amy, but Amy's probably thinking December is too late to be coming back to this meeting to kind of share that with people. So I'll challenge myself and my team, Alison's team, to go back to September if it's at all possible.
Thank you.
Can we make a note to have that update subject to availability and processes, so that we just keep that on our radar. John, please.
Yeah, I think it's good that we're going to add the risk appetite statement and the risk register to all IJB meetings, including our committees. And it's good, I think, that as on this agenda, it's quite high up the agenda, so that we can actually, when we're debating and looking at particular items, we've always got in our mind what potential risks are. So I think that's good. And then a question around the fact that it says from time to time the IJB may decide to deviate from its agreed risk appetite. Where this is the case, it'd be important to exercise judgment. I think that's fine, and I think I've read this. Implicit in that, I think, is that where we did decide to deviate from the agreed risk register, when we minuted that decision, we'd have a clear explanation as to why that was, which I think is good for governance and good for helping an audit trail. So as I say, I think it's implicit, but just want to reinforce that point.
Martin, did you want to come back to that?
No, happy to note that. I think that that kind of clear explanation and minuted decision would be helpful to the IGB and to SLT as well.
Okay. Any other questions for Martin? Okay, the recommendations are on page 33. I would ask Emma if you would mind just reading through the recommendations so we're all clear what we're agreeing to. If you could.
It is recommended that the Integration Joint Board approve the Integration Joint Board advised risk appetite statement as detailed at Appendix A. B, agree that the risk appetite statement to be added to the agendas of the IGB Clinical Care and Governance Committee and to the Risk Audit and Performance Committee, further support the board and committee decision-making process. And C, approve the revised summary of the IGB Strategic Risk Register as detailed at Appendix B.
Are we happy to agree those on block? Yeah, thank you very much. And thank you, Martin, as always. Turn now to item 6.1, the review of scheme of governance review 2025, pages 49 to 146. And for guidance, I would advise colleagues that there are 2 versions of the standing orders included in this. One includes the track changes from 2024, and one is a clean version with those changes approved. We thought it'd be a good idea to include both of them just because we know that people sometimes have challenges with tracked changes. And I would invite Jess and colleagues to speak to this as you wish.
Thank you, Hussein. Good morning, IGB members. Today you have before you the annual review of the IGB scheme of governance. There were notably 2 main changes in the scheme: the revised standing orders and the terms of reference for the appointments panel. Members should note that the standing orders are not governed by the same legislation as council committees, but notwithstanding that, some standing orders are required by statute, and these have been flagged in the proposed standing orders for ease of reference. The main changes proposed relate to the processes for formal proposals being submitted and equality of votes. In relation to the process for formal proposals, the suggested changes have made reasonable adjustments to the timescales for which a proposal, which is substantially different from the recommendation in a report, can be made. This aims to ensure that meetings run efficiently and that members get as much advance notice of such a proposal after it has been deemed competent, so that members can have time to consider and reflect upon it prior to the meeting rather than during it. It should be noted the IGB is encouraged to continue to discuss recommendations openly, to collaborate, challenge, and where necessary, put forward for consideration any suggestions an IGB member may think might be relevant. I'm happy to take any questions.
Thank you very much, Jess. And what Jess is too polite to say in the meeting is that the changes also help with ensuring the health and well-being of our staff as well, in that they are working according to their set hours, and that they have time to continue to do the work that they do, which is, as always, exceptionally high quality. I'm grateful to Jess and colleagues for taking the time to turn this around in fairly short order, and also for the engagements that they've had. I'm also grateful to John for his support with some of the changes. I know he must have wondered just what roller coaster he stepped on when he heard my list of proposed changes, but I'm grateful nevertheless. I think that they improve the efficiency in the way in which we do business, and improve the inclusivity and access to not only those attending the meeting, but also to the people that we serve. Are there any questions on this? Mohammed.
Thanks very much, Chair, and thanks very much, Jess, for your report. Although you clarified your introduction that these are not changes like Aberdeen City Council. But does this scheme aligns with Aberdeen City Council standing orders and just Grampian protocol are recent legislative update Act Health and Care Act 2024?
Yes.
Sorry, was the question, has the timescales been influenced by the council or NHS Grampian?
No, I repeat my question.
Sorry.
How does this scheme align with Aberdeen City Council standing orders, NHS Grampian protocol, and the legislative Act 2024 Health and Care?
So the statute that I refer to in my introduction there relates to a statutory instrument that sets down specific requirements that IGB standing orders have to have in them. Members will note that they're flagged by S, which means statutory, in the proposed ones that you have, and NS for non-statutory. In particular, the areas around voting and what happens in a dispute are not set down in statute. The only requirement in the statute around voting is that the IGB does that by consensus and majority. There are, to some extent, some experiences that we have considered taken from Aberdeen City Council's recent change in its scheme of governance around timescales to allow officers enough time to be able to consider proposals that are submitted. And that's really the changes and the influences there.
Thank you yourself, Chair. Sorry. Thanks very much. Yeah, of course, consensus is good, but not all the time. This is not about just blame, but consensus that got NHS Grampian to stage 4. It was consensus that got this IGB to spend all its reserve, and it was consensus that meant we had to bring out the begging bowl and ask our partner to bail us out. So basically, all of our standing orders are in relation to consensus. But there is but a good transparency and accountability that you cannot move any amendment. And when you stand up and you highlight something, and then you cannot get anybody to second. So basically, your standing order is purely about consensus, not difference of opinions.
If there's anything that you particularly want to comment on, Jess, otherwise.
No, thank you.
Okay, thanks very much. So my next question, I don't think anybody can comment, because it is about transparency, accountability, which is important. But is there any schedule training or inductions on governance update for the IGB members and officers. Because we had experience when we changed our city council and so many convener and vice conveners struggled to understand the difference between standing order and legislation. So have you set up anything to just have some kind of training for all 8 members?
Sure. Yes, thank you. I am aware that there's been recent induction training for new IGB members, particularly around the process for voting, and that was done earlier this year.
Thank you.
Thank you.
Any other questions for Jess? Okay, I turn to the recommendations on page 49. And I would ask Emma if you could read the recommendations as are.
Sure. It is recommended that the Integration Joint Board A considers and approves the revised roles and responsibilities protocol as attached at Appendix C. B notes that there are no changes to the IGB carers and service user representative expense policy. C notes there are no changes to the code of conduct. D agrees the establishment of the appointment panel committee and notes that it will only meet when there is business to determine. E agrees the terms of reference for the appointments panel attached to Appendix C. F considers and approves of the revised standing orders for the IGB as attached at Appendix A. G agrees that the chief officer shall, where necessary, make arrangements to secure interim cover for the chief finance officer role. And H instructs the chief officer to upload the revised documents as approved to the Aberdeen City Health and Social Care Partnerships website.
Thanks, Emma. Are we happy to agree?
Agreed.
Yeah, thank you very much.
Sorry, I had an amendment.
Mr. Ball.
So it was with the officer, and I thought I was hoping that you will give opportunity for myself if I can get anybody to second. Of course, if nobody can second, we can move on, but there is process and my amendment.
Yeah, I think a fair point has been made. I mean, I did ask for the recommendations to be read, and the reason I allowed that time was specifically for any interjection. So I'm not going to take your amendment on this occasion, but I do think I've been fairly lenient in allowing time for people to interject if they did have an amendment. I think you had a good chunk of time to do that. So I won't take the amendment on this occasion, but I would draw your guidance to that in the future.
Thanks very much, Chair, but my amendment was with officers.
I appreciate your amendment was with officers.
And I was expecting that officer indicated to yourself, Chair, that there is amendment from Councillor Malik and can be taken, but not just rubber stamp, happy, approved. That's not transparency and accountability at all. It doesn't matter if I get somebody to second me or not. I very proudly, I will keep moving my amendment if I believe that I have to. I'm not actually embarrassed that nobody can stand up and second me. We had a lecture earlier on for transparency. It's really transparency. My amendment as the officer since yesterday or day before, and then today you have not taken. Thank you.
And I have no objection to your amendment if you move it. And in this case, you did not move it. I turn to item 8.1, which is the strategic plan on pages strategic plan 25 to 29 on pages 211 to 330. I'm pretty sure most people don't eat strategies for breakfast, but they are fundamentally important and they underpin the direction of travel for our IGB over the next 4 years. And underneath that, they underpin then the operational delivery of services and the experiences that people have each and every day. The strategic plan is the combination of years worth of work. I was once told that we start working on the new strategy as soon as the old one is signed off. It's been the subject of a number of iterations, and colleagues may remember the draft strategy that was brought to us earlier in the year. And it's also been the subject of extensive consultation. I'd like to take this opportunity to thank the senior leadership team, everybody that's been involved in the strategy development, I'd like to thank all of the groups and communities, our partners and stakeholders who've been involved in the consultation that has fed in to what we have before us today. I'd also thank the external support that's helped us to make sure that our strategy is fit for purpose and serves not only the needs of our communities now, but I think very importantly, all those who may need our help in the future. We've learned lessons from the past, and one of the largest pieces of feedback was that our communities wanted to know why we do what we do, and to close that feedback loop. And that was a challenge that I also set to the leadership team, and they have responded in their usual indomitable anti-ebullient way. And we have a section in the strategy that tells us the changes that have been made. You said we did. This strategy also aligns with a number of documents that underpin local planning and decision-making, showing our commitment and the importance of integrating services, and also demonstrating just how many aspects of life feed in to health and social care. I commend the strategy to you, and I invite Alison and colleagues to speak to this as they wish.
Thank you, Zane. I think you've pinched some of my my intro there. So the strategic plan that you have in front of you just now is very much updated from the draft version that you saw earlier in the year, although the strategic aims and priorities remain the same. We have added a 4-year route map for delivery, and that's contained as an appendix to the plan. We also have a detailed year 1 delivery plan that's already in progress, particularly in relation to the budget savings projects, and additional detail of the transformation projects will be submitted to the Risk Audit and Performance Committee in August, along with a Q1 progress report. In terms of the strategic plan itself, we thought it was important to set the context of the plan, which is why we have included details of our current service delivery, our approach to the way that we deliver our services, and the key components of the development of the plan, particularly in relation to what the data was telling us, the impact of inequality, and of our current budget situation. We've included a section on the outcome of public consultation, and as Hussein has already mentioned, we've laid that out in a you said, we did format, although there will also be more detailed feedback provided to those who participated in the consultation. So the revised strategic plan is in front of you for final approval. I hope you also see in your reading of it that we have made some really strong alignments to both the medium-term financial forecast and to the strategic risks. So happy to take any questions.
Thank you very much, Alison. And once again, thank you to you and your team for all the work that goes into this. Developing this is certainly not easy, and you've done extremely well. Are there any questions for Alison? Martin.
Yeah, thank you, Chair. This is a very strong, detailed, credible plan that we have for the next 4 years. And I'd like to ask about how it will be implemented. I think the value of the very careful work that's done, that's gone into producing this plan will ultimately be tested by how it's actioned and how it's able to respond to the changing context, to the varying and likely increasing needs and demands from the public. I think it's very much an evidence-based strategy that we're looking at. I think that's a real fundamental benefit for our future planning. But how are we going to continue to interact with this information, with that evolving, developing environment around us, including likely, ongoing resource pressures, budget problems, and so forth? Because we want to be able to scrutinise this strategic plan over the course of this year and the other 3 years. How do we do that?
Awesome.
Absolutely. So the implementation of the strategic plan will be via 4 in-year annual delivery plans. And those delivery plans will contain detailed projects along with timescales for delivery and how we are going to measure them. So as we go through each year, we will monitor our progress on delivery of that year's annual delivery plan. And we will also take cognizance of any emerging priorities, any changes to the environment that we're working within. And that will feed into the development of the next year's annual delivery plan. And we'll continue our quarterly performance monitoring, or reporting, sorry, to the Risk Audit and Performance Committee. Our senior leadership team will continue to have the delivery of the strategic plan on their monthly business meeting. So there will be lots of opportunities to monitor that. And of course, our main vehicle for reporting our performance is our annual performance report, which will come to the IGB each year.
Great, thank you very much. That's all extremely reassuring. I'm very conscious that we're looking at a vast amount of work. Everything is very carefully coordinated, and obviously the teams will have to be very agile to respond to the changing context around them. So that's a huge responsibility, because everything is interlocking so closely, and there are, as we've seen in the previous items, there are risks such as the cost of commissioned services is a risk, but then we've also got some positive opportunities, such as the family support model, which we could link in some of the transformation projects, like the technology enabled care that we've already touched on. Everything, I think it's very impressive what's been produced, but that is going to continue to be a major challenge to keep everything interconnected. But at least we have a structure, and we've got a route plan, and we also have a structure. We also have a structure for scrutinizing and for decision making, depending on how things pan out. Thank you.
Go to Mark and then Richard, please.
Thank you, Chair. I think this is more of a comment than anything else. Thank you for the strategic plan. It's been a good reading. I think the linking of the strategic plan to the financial aspect is the most important thing that I've noted on this report. I think I welcome the Chair's moving this up the agenda to allow it to flow better through the meeting. I think that's really important. I said just more about my comment than anything else. I just think it's really important that we align those two things. We keep our, I said this before, strategic plan as realistic as we possibly can, but then the resource elements. Comment on anything else, Chair. Thank you.
Thank you, Mark. Over to Richie and then John. So Richie.
Yes, some more comments actually to Martin and Mark. I like the way it's been put together, and that kind of alignment is really good. And I think that visibility of the annual delivery plan and how they'll support the workers is really good as well. And it was on that I just had a question around the current year's annual delivery plan, and how something that's been agreed today on the MTFF, I guess, is what impact might that have on the current year's annual delivery plan, and does that schedule come back around this table just for a reflection, or just feel maybe be for the current year? I appreciate we'll get into a pattern of future years being informed by the issues raised in the current year, but more just a practical one around about just the here and now, if you like.
Awesome.
Yeah, so we developed the year one annual delivery plan as we were developing the strategic plan, and some of the main drivers for in that are the budget savings projects, so they're key there. But we felt, because we were so far through the first year, if you like, before we were coming to bring the strategic plan for approval, we felt it was better just to let that annual first year's delivery plan go through the normal processes to Risk Audit and Performance Committee. But we can certainly circulate the year one annual delivery plan around IGB if you want that visibility. But you will see the progress of the delivery of that through the reports that go to Risk Audit and Performance Committee.
Thank you.
Are you content, Richie, if we have that circulated?
Yeah, be totally selfish. I'm on Rap C anyway, but yeah, go for others.
Yeah, thank you. Okay, so we'll make a note to have that done so that everybody has sight of that. We're all on the same page. Come to John, please.
Yeah, thanks. Yeah, totally agree that the linkage with the strategic plan and the financial plan is really important, and that's clearly in there. The one question I've got is around health behaviours, where we say in the report, health behaviours account for 30% of your health, whereas health services are only accounting for 20%. And it's kind of one of those things where I wonder if we could, sorry, I should have asked you this before, maybe have an insight session on what we're doing on behaviours, because it sometimes feels to me like it's a bit like painting a footbridge, or you can lead a horse to water but you can't make it drink, particularly around vaccine uptake, where you've got all these folk who are conspiracy theorists. So I just wondered if that's something you might like to comment on it, what we're doing already, and clearly we are doing some stuff already, but whether there's anything we could do further on that.
Yes, absolutely. So there's lots of discussions ongoing at the minute about how we can influence health behaviours, and that is something that's really difficult to do because everybody's individual. So you're not necessarily going to have a one size fits all. So there's lots of things. I mean, the community appointment days are one way of hopefully trying to influence. There's lots of work going on around about some of our Lloyd projects, around about the uptake of the cancer screening. Vaccination team do a lot of work around about uptake of vaccinations. But I think one of the key things that we're working on at the minute is just that engagement and communication with our communities. We have community representation on our strategic planning group, and whilst they're very grateful for the information that they get right by that forum, that we're very aware that that's not necessarily available to the general public, if you like. So increasing our communication and engagement with our communities is very much key to making this happen. But happy to have a session at one of the insight sessions to try and get some ideas from around the table. If anybody else has any other ideas as to how we can help influence those behaviours, we'd be delighted to hear them.
Subject to being able to fit it into all the other things.
I was going to say they are getting a bit busy.
So.
However, we'll make it happen.
We'll leave that. Yeah. So let it not be said that I neglected the folk online. So I'm going to come to Phil, and then I'll come to you, Mohammed, if you like.
Thank you very much, Chair. I just wanted to follow up on a couple of comments, if I may, in relation to behaviour change. Whilst obviously there is, as Alison's been outlining there, a focus on individual behaviour change, as in the individual whose health we are seeking to improve and promote, we shouldn't lose sight of the opportunities that there are from within the Health and Social Care Partnership and our wider partners in looking at the way in which organisations help and support that behaviour change on the part of the individual. I think we shouldn't underestimate the importance with things like the community appointment days, that is a change which is an organisational change, which then supports individuals to be able to have a greater degree of agency within their own health and healthcare supports. And I think when we start talking about areas such as Healthy Weight Aberdeen as a whole system, when we talk about public mental health, when we look at active ageing, all of which plans are embedded in the first year of the current strategic plan, Each of these recognise that balance to be found between the organisational supports that create environments which help individuals to sustain behaviours that they change long enough to see the health benefits come through. So that was my first comment. And the second one, we do need to understand how individuals need to be supported in dealing with the underlying social and economic elements that determine their health, many of which are beyond their individual control, but are organisational issues that require collaboration across organisations to deliver sustained change.
Thanks very much, Phil. And I'll come to Mohammed.
Thanks very much. Linking strategic plan and financial forecast good. So my question is the IGB forecasting a deficit in any of the next 3 years? And if so, what are the underlying structural pressure and when do they peak?
Is that Alison or Amy?
Maybe ask Amy to take the
Yeah.
question.
Thanks. So the medium-term financial forecast, which we'll come on to next, does highlight the financial challenge in each of the next 3 years. But we look to put plans in place to save money in order to reach a balanced budget position. And that I'll come on to talk about that in the next paper, if that's okay.
Mohammed?
Thank you.
Any other questions? Nope. Okay. I now turn to recommendations. And I would ask Emma if you could just leave those. They are on page 212 of the pack.
Sure. It is recommended that the IGBA approves the strategic plan 2025 to 2029 and B, instruct the chief officer to publish the strategic plan and instigate the formal launch and promotion activities.
Is anyone otherwise minded? Or are we happy to agree the recommendations?
Agreed.
Yeah, thank you very much. I turn to item 8.2, which is the housing contribution statement on page 331. Who is speaking to this?
That's me again.
Yourself, yeah, okay, please go ahead.
So the housing contribution statement that you have in front of you is largely unchanged from the previous draft version that you saw earlier in the year. The housing contribution statement is a requirement of the legislation, and it details the relationship and links between the partnership and Aberdeen City Council Housing, working together to support the health and well-being of the people of Aberdeen. The local housing strategy was also consulted on at the same time as the IGB strategic plan, and feedback from that was also considered in relation to the housing contribution statement that you have in front of you at the minute. The local housing strategy is going to committee for approval in August, and once approved, the housing contribution statement will be published, and relevant links from both the IGB strategic plan and the local housing strategy will be made to it. So happy to take any questions.
Thanks, Alison. Are there any questions for Alison, please?
Yeah.
Martin.
Yeah, just a quick comment that it's really welcome to see recognition of housing condition as a factor, as a determinant in your health. And I think this is a key area where we need to see that joining up, particularly around health inequalities. I know so many cases where people have substandard housing, leaks, mold, and so forth. So I think that this approach, which integrates health into housing need, is really essential. So it's good to see.
Thanks, Martin. Richie?
Yeah, thanks. Again, welcome to the paper I set out. It's a question on the disabled adaptations group on page 339. And I guess it is a whole system point again. And I guess just understanding, I guess, how that work is done, and is that linking, for example, to assisting with delayed discharge, people coming to hospital. I know it's all 10 years, and I guess just any comment on the challenges around that and just how that whole system process works in that in that setting would be helpful. Thank you.
Thanks, Richie. I think it's important to recognise that pressures in one part of the system invariably have an impact on other parts of the system. But Alison.
Yes, absolutely. That was one of the main reasons for the disabled adaptations group coming together, and for ensuring that we have all partners around the table, including our registered social landlords, who are key to providing that service as well. And what we do is we understand the issues that all tenures have. We've got the private sector housing grants folks around about that. We've got our representatives from our council houses. We've got Care and Repair, who do some low level adaptations. They're a charity, so we do fund them to some extent, but they also bring a lot more to the table in terms of additional charity funding that they can access. Our registered social landlords, as I say, so we're all round the table. We're all hearing what each other's problems are. We're trying to make the best use of resources. We quite often adapt a property and then people move on, they go into a care home or whatever. So we've got an adapted property. We've got neat and we've got adapted properties all over the place. And what we're trying to do in the disabled adaptation group is make sure we're making the best use of our resources by utilising as far as we can, because obviously people have tenancies and you can't always move them from one type of tenancy to another, or not easily. So we're just trying to make the best use of that. But the group are now looking at sort of modular equipment that is easily that we can disassemble easily and move around. So that's one kind of initiative that the group collectively have kind of focused on. So they're a really enthused bunch, and we get a lot of work done in that field.
Yeah, very helpful. Thank you
very much. Any more? Lee, please.
Thank you so much. Thank you, Chair. I was just kind of interested about how the rising number of adults choosing not to have children and how this will likely different housing models in the future. I was just wondering if that is around here as well. I was just wondering if that is something that we're starting to look at now, or if that will require further data and trends, or something we're anticipating.
Yeah, absolutely. We are starting to look at that now. We're also think about how that impacts some of the other ways that we work. So our carer strategy, for instance, if people live in a family unit, quite often there's there'll be carer, their family will care for them. But if they're single and they don't have family around about them, then that would perhaps put more burden on mainstream services. So absolutely, we're beginning to think about how that could impact. But we will track the trend and make sure that we're up to date with how that, whether that is increasing exponentially or
we're not going to be caught short on that.
Well,
we might end up
it's very difficult to predict these things, and it's very difficult to also understand what bespoke services these people might need. So, but we will keep an eye on it and try and respond as best we can.
Great, thank you.
Mohammed.
Thanks very much, Chair, and thanks very much for Alison for your report. How does the housing contribution scheme statement directly support the IGB strategic priorities, such as shifting the balance of care, preventions, person-centered outcomes?
So housing is a very important part of people being able to live healthily, safely at home. So ensuring that we've got the correct housing for people that supports us them being able to live in their own home for longer independently. And if their house is not contributing to their ill health, then that reduces the burden on services.
Any more? Okay. That being case, we turn to recommendations are on page 331 of your pack, and I will turn to Emma for those, please.
It is recommended that the IGB meets the content of the housing contribution strategy and the links between it, the IGB strategic plan and the local housing strategy, and instructs the chief officer to publish the housing contributions on Aberdeen City Health and Social Care Partnership's website and ensure it is linked to both the IGB strategic plan and the local housing strategy.
Is anyone otherwise minded, or are we content to approve?
Agreed.
Agreed.
We are, thank you. It is 11:31. I propose that now is as good a time as any to take a short break. If we can come back at 11:42, and we'll continue with the rest of the agenda then. Thank you for your participation thus far. supported and if that was your choice, and then we're good to proceed. We move back to 7.1, which is the medium-term financial strategy, pages 147 onwards. And I would ask Amy to speak to this as you wish.
Amy, are you there?
A minute early. Yeah, you got a minute early. Yeah.
She's making the most of the time.
So I could sneak an extra 50 there.
Oh, I've seen someone do that before. They put their hand for an extra minute.
You win something.
There she is.
Right.
There she is.
Okay, so we now turn to we do now turn to 7.1, the medium-term financial forecast on pages 147 through 158, and I invite Amy to speak to this as you wish. And sorry for depriving you of the last minute of your tea break there.
Not at all. Thanks very much, Chair. The paper that we've got before us and the medium-term financial forecast helps support the underpins really the delivery of the strategy and sets the direction of travel. The document's been updated from the paper that we had at the time we set the budget, and that's reflective of the strategy paper that's been brought forward. What we recognise is that as we move forward over the next 4 years, that there's going to be a continual requirement to kind of look at the financial direction of travel and understand how the budget can be balanced each year. So whereas Councillor Malik asked earlier in the meeting, what are the financial challenges and how will we balance the budget? This paper helps to explain that. We understand that the demand for services will continue to increase and that we have the start of the preventative agenda, or the continuation of the preventative agenda working against that. But we anticipate that the positive output from prevention won't be quite enough to mitigate the additional demands that we face as an IJB. And kind of having that recognition means that we need to be thinking ahead on how we do manage the costs of service delivery and how we reduce that in future years. We've talked very much about the tech-enabled care, which we know from working with service providers, they are keen to work with us on, and that helps significantly in improving and reducing costs of care. We also look to reimagine how care is delivered, particularly through using technology, and with the social care app funding that we have, that helps reduce infrastructure costs as well as improving the interface that we have for people using our services. And these all managed together help us move forward to produce a balanced budget in future years. Also, I have noted as well that we're aware very much that the environment that we have based our planning on just now is based on the knowns, what we know, but we are aware that NHS Grampian was escalated to stage 4 of the National Performance Framework earlier in May, and that as a result of that there may be output that we need to manage from that in our future financial planning cycle. When we look to the medium term over the next 4 years, it's not just our two partners that we look beyond that and understand the inflationary pressures, the rising demand, how the impact of Brexit and having immigration affects how we deliver our services. And particularly within that, we have to balance our budget. So we've recognised what we anticipate our pressures will be over the next 4 years, starting off from 25-26, if you like, being about a base year. And in each of those years, we expect there to be a pay award. We expect that people will have an inflationary pay award, which we've set at 3%. And if it's above that, we will have to work with our funding partners on how we manage that. We understand that based on recent forecasts, prescribing costs will continue to increase. We understand also that our commissioned services will continue to grow beyond probably the real living wage increases we have from Scottish Government. But as I've said, that's something we very much need to keep on top of. And that also we have to anticipate that we will have additional demand that comes through into the system, particularly because we have an ageing population, and that's very much recognised within the strategy document, which is brought forward as well. When we take all these factors together and we build in our future anticipated funding from each of our partners, we can see that in 26-27 we would anticipate just around a £14 million budget gap. And if we don't address that £14 million budget gap, that grows in subsequent years as we understand what the inflation is in each of those years. So very much this plan highlights that it's very important that we make those savings, that £14.354 million in the current financial year, and then there's another significant financial challenge next year. And as articulated in previous meetings, that really is addressing, if you like, the structural deficit that the IJB has been working with for many years. And as we no longer have any reserves balances that we can use to kind of fill that gap, it's very much now is the time that we need to address that. The plan highlights what that looks like based on the current set of assumptions, but also takes into consideration the risk associated with that. If we anticipate that we make all our savings, then we're in a good place. But if we were only to achieve 75% of those, for example, next year, it would still leave us with a deficit of around £3.5 million that we would need to look to manage. Because there are 9 months before we start the beginning of the next financial year, we've got a good amount of time in order to fully mitigate that risk. If we assumed that we delivered only 50% of our savings next year, we'd be looking at considering whether our systems were working properly and on order to actually deliver those savings. So I put down there, if you like, the actions that we need to take as an organisation to make sure that when we bring forward our budget savings options, they are robust. There's been the appropriate review of how a saving will be delivered, that there's a plan in place, that people own that plan, but they understand the actions that they need to take forward, and that they can understand how they can manage the risks as they go through that process. And also we've talked about RAPC very much in this meeting, what an important role they have in terms of the processes that are used to manage the savings delivery, and actually that monitoring process which then IJB take on is already kind of having that review and RAPC, and how that governance process will work effectively through the governance of the IJB. So that gives some degree of assurance to members around how we would look to go forward with pushing forward what will be critical plans, particularly over this year and next year. So that's really a very high level summary of the paper. And of course, I'm happy to take questions on that. Thank you, Chair.
Thank you very much, Amy. And as always, for that very concise and easy to understand explanation. And also, thank you for that modelling and that scenario setting we asked in a previous meeting, if you would bring forward some of that sensitivity analysis, and you've absolutely done that. So that's very much appreciated. I also absolutely agree with you when it comes to getting that buy-in and that ownership from budget holders who will be doing the work of implementing the proposals that we bring forward. Are there questions for Amy on the MTAs?
Thank you, Chair.
Martin and then John.
Thank you, Chair. Thank you very much to Amy for the excellent quality work in putting together the TFF. It's really appreciated. I've got a question about the work on forecasting risks in balancing budgets. So I think it's really helpful to see the that categorization of 100%, 75, 50%. But what is the likelihood, or can the likelihood be predicted of only achieving 75% of the savings, or of 50% of the savings? I think that would be quite useful to have an indication of whether we're able to predict whether that might happen, and when would we be informed? So the performance monitoring, would this be coming to every IJB and or RAPC? Thanks.
Amy?
Yeah, thanks very much, Councillor Gregg. In respect of the risk of non-delivery, so my anticipation would be at the start of the next financial year, there would be a plan in place which clearly articulates how those savings can be delivered. And if that savings plan wasn't moving forward in the direction that had been intended, then there may be some slippage during the year. I think it would be incumbent on officers to look to see how those gaps could be filled during the course of the year. And I think through RAPSI, the process of how that is done would be monitored, and certainly a financial update brought to IJB on what that progress is. It is quite normal that you would have slippage and change in projects. We've all experienced that. Projects can be slightly behind, or alternatively, they can be ahead. I think the importance of the IJB will be to hold officers to account for that. Certainly this year, the savings plan has been put together and there's clarity on where those savings are being pulled from. The same would happen next year and in subsequent years.
Thank you. Happy with that. Thank you very much.
Thanks, Martin. John?
Yeah, I've got a couple. Amy, you mentioned that we've now used all our reserves. Can you remind me how many IJBs in Scotland have also used their reserves? I know it's the majority, but can you remind me of the current number?
So there's 30 IJBs in Scotland, and all of those IJBs have pretty much used all their reserves. I think there's only one IJB that may have enough money, which is Eastern Bartonshire, to cover, if you like, a full year's worth of operating budget deficit. But certainly we are in a very similar position to every single IJB in Scotland.
Thanks for that. And next question is on increases in demand. We know Scotland-wide over the last 2 years, demand and therefore cost on adult social care increased by 17%. We'll say that's Scotland-wide. I haven't seen, at least I don't think I've seen any kind of projections forward. Do we have any sense about how we are projecting the increase in demand for adult social care in this year going forward?
Certainly there's a number of people working on projections just now, and public health are involved in that. I did a bit of kind of research to see what we could get forward to actually understand what the percentage increase is, because as Alison's highlighted, through the strategy, we expect a growth in people over 65 years old, people in 75 years old. What we want to put alongside that is, if you like, the really good work that's kind of occurring across how we develop care in the community and how we are able to take care of people better in their own home rather than a residential setting. So what we're looking at with an increase in demand is understanding where it's coming from, but also how we can work with that demand and mitigate it. And certainly we have been, particularly through our chief nurse, looking at the funding that's been available from NHS this year to help us develop different pathways. So when we have people coming out and being discharged from hospital, how we make sure those people can be fully independent going forward rather than having a continual need for care. So it's not just about how the demand is coming through, but what we're doing with it and how we're looking to manage that model down. And certainly when the strategy was put together, there was some really, really insightful research and information we got on New Zealand and the models that are used in New Zealand. And if we can adopt some of those ways of working, which we are looking to do, then that has a significant positive impact in terms of the future cost base that we might expect to experience. So I think it's lots of things together. It's not just the pure increase in demand is X amount of people into the system. It's how we help and improve people's health outcomes, as well as recognising that absolutely we'll still have that short-term kind of high increase that we're expecting, but how do we manage that over the course of time is very much, I think, a very positive way of looking at how the Health and Social Care Partnership stands to gain in the future.
Thanks for that, and for all your hard work, and good luck in your next venture.
Thanks very much, John, and that's also helpful context to look at the wider picture across the nation as well. I'll go to Mohammed and then to Richie. Mohammed.
Thanks very much, Chair, and thanks very much, Amy, for your comprehensive report. And we had this question in relation to how many IJB used all of their reserves. Can you please tell me, is it good to use all of the reserve for any organization? And the second question you might not be able to answer. And only 3 years ago, we built up our reserve. And can you tell us what was our result in 2022 and how much we used within 2 years?
Amy?
Yeah, thanks very much. So I think the IJBs in Scotland, very much just as we've done, have followed the integration scheme when they've been using their reserve balances. Certainly for our IJB, I'm aware that in the 23-24 year, we used £17 million worth of reserves. And in 22-23, I think it was around £27 million of reserves that were used.
Thanks very much. And my next question is in relation to financial planning and assumption. So what assumption have you made around Scottish government settlement and funding from our partner like Aberdeen City Council and NHS Grampian?
Amy?
Yeah, I've assumed the same level of funding continues each year, but I have noted that in respect of NHS funding, that may change as a result of future plans that are developed, and we would very much respond to any actions that are placed on us as a result of that.
Thanks very much. And my final question, Amy, is there scenario planning in case demand grows faster than expected?
Yes, so if demand was to rise faster than expected and we had a requirement to support more people, then we would need to manage our budget around that. And certainly that would be no different from having to look at any other pressures that we may experience during the course of the year and just needing to plan around those.
Thank you very much. I mean, that's great.
Thanks, Mohammed. Richie?
Yeah, thanks again. Thanks very much for the paper. What the strategic context you just agreed in terms of the way forward. We've also got now the financial framework set out before us. The risks, I think we've been well discussed. We've well discussed that today as well, and also now about the delivery of it. I guess it's just that maybe to reinforce that point is what I was going to get on with it, as Amy's going to set out. And for us as the IGB, whether it's RAPC or the IGB here, they just keep a close eye in terms of how that financial plan is coming to fruition. And my ask is related to the point that Councillor Mallett just made, that latter point there about, I guess, any changes, and I guess for us to have as early sight as possible about any risks potentially materialising in terms of our assumptions, whether that's around funding or whether that's around demand or whether that's around cost pressures that may or may not be a surprise to us. So as soon as we get some hint that it might go slightly off key, then let's be totally transparent. Let's have that round the respective tables so we can then talk it through and see what mitigations might be possible in order to bring us back in line. So I guess just I'm sure none of that's news to you or a surprise, but I think for us it's really important just to get early sight of any potential changes in terms of how the forecasts are coming to fruition or not. Thanks.
Amy, just if you wanted to add any comment to that.
I think as through just echoing Richie's point, I think it's important that as we go through the year, each of the quarterly reports highlight where we are on our journey and how we're moving forward. Certainly we haven't got the results we're just the 1st of July today. So today is the start, the second quarter of the year. We'll be working on the results from the last quarter and have that position and be able to share that with members at the next IJB.
I have a question that I meant to ask it earlier, but seeing as you have you brought it up in your narrative there, I'll use some creative license if I may, and that is around it's an unescapable fact around the NHS Grampian escalation to level 4 of the framework, and I just wondered in terms of bringing members right up to date, colleagues will be aware that the external diagnostic review is now in progress. It's inevitable that changes that affect our partners may well affect ourselves as well. And I just wondered if there was any update as to discussions that had taken place with any of the IGBs in North East of Scotland as part of that diagnostic, if there's anything that you can or wanted to share.
Thanks, Christine. I'll come in there. So there was mention at the beginning at the Commission that there would be interaction with the IGBs, but there are no plans to speak to the chief officers or the CFOs for the IGBs as part of the process at the minute from the diagnostic review. which is due, we should get the report back on the 14th of July.
Thank you. We'll be waiting with bated breath to see that and anything that comes from that report, because if we are to have an integrated system, then undoubtedly there will be effects that cascade through it. Are there any other questions for Amy?
Sorry, Chair, just
Yep.
for me. Thank you very much, Amy, for the report and all this. I've listened to everybody else's comments. My only comment is on balance. Okay, and I bring this up every time, that when we have a financial balance, we have a clinical governance balance or a staff governance balance as well. And I think that it's very important that we realise that with our savings that we have to achieve, there's no doubt of that could have impacts within our clinical delivery and our clinical governance, and these will be highlighted through the clinical governance committee, obviously, which I chair. So I think that we'll be to watch that very carefully, that we don't have too many risks developing around that. So it's just a comment more than anything else to keep that balance in mind between finance and clinical delivery governance. Yes.
Thanks. Any other questions? No. Okay, I therefore turn to recommendations. I'll just go through them first, and then we'll see if we're doing anything with them. The recommendations are on page 148 of your pack, and I'd ask Emma just to go through them.
It is recommended that the IGB notes the further development of the medium-term financial forecast as the new IGB strategy is brought forward. MTFF sets out anticipated cost pressures and future funding projections based on planning assumptions to allow the IGB to work towards financial balance under the new strategic plan 2025 to 29.
Is anyone otherwise minded? Or are we content to agree the recommendations?
Agreed.
Agreed.
We are agreed, thank you. Item 7.2 is the Alcohol and Drug Partnership Annual Report 2025, pages 159 to 210 in your pack, and the appendix on page 177. I believe Simon Ringer is taking this. And I'd like you to speak to the report if you wish.
So thanks for your time today. This paper is an update on activity undertaken by the ADP Alcohol and Drug Partnership. It combines an update on work progressing the ADP's 3-year delivery plan and highlights particular work progressed in 24-25, along with other partnership bodies, including Health and Social Care Partnership that we've heard today, and community planning. We are refreshing and progressing a future delivery plan. At Appendix 1, there's a Scottish Government survey, which the government require us to sign off at an ADP level and an IGB level. The survey is not a performance report, but it surveys particular topics and gaps to inform future planning by the Scottish Government. And there's a recommendation in relation to that. I'm happy to take any questions.
Thanks, Simon, and thanks to all the work that your team do across the city as well. This is obviously a key area of focus for us. Ask if there are any questions for Simon. Yes, yeah, sorry. Martin.
Thank you. Thank you, Chair. I've got 2 questions about the questionnaire, if that's okay.
Yep.
The first one is about the drug debt reviews. It's very stark, yes, no question there. But you know, it does raise queries about that wider issue. Is there anything that you can provide us with on drug debt reviews?
So, in terms of drug death reviews, I mean, we have an independent reviewer, so Katrina Matheson, who was the chair of the National Drug Death Commission for a period of time, and is a professor of substance use at Stirling University. We contract her to provide an independent review of deaths within service and people who have died out with service. There's a multidisciplinary team that's part of that review. It involves professionals in terms of social work, police, clinical staff, social work staff, etc., housing staff, and they produce an individual report for each death, and they collate a thematic report on any issues that might be emergent in the city or any changes or anything we can learn. That information helps inform our strategy and our developments, and on occasions we have undertaken specific reviews for particular cases that have been maybe involving young people or more complex situations, and we keep the Chief Officer Group of HOG appraised of any sort of outstanding or unusual events and information.
Thank you very much. That is very reassuring. I took the opportunity of asking about a very specialised area of activity. It was worthwhile highlighting that that particular issue is so major, and it's good to know that there's focused individual help being provided, and there's that strategic view being developed as well. So that's good to know. I had a second query, question 34. So the question asks if there's specific treatment and support services for specific groups. If our answer is no given, because there's an inclusive approach anyway, so you don't need to provide targeted help to those specific groups. They're already part of the overall treatment, care and service delivery.
Yeah, it's a combination. There are some particular outreach groups that we undertake. So people who, women who are pregnant, etc. You know, there's particular things that we do around that because there's a vulnerability. But the other services, in terms of specific treatment, there isn't a specific treatment, for example, for people with substance use issues who are veterans, for example. What we would aim, as I say, to be inclusive, and if there was an emergent theme or trend or change in our population, we would have to reconsider and maybe offer something to them in a different way, or try and learn from them.
Thank you. I mean, I know that there's not an indication for people with learning disabilities and literacy. That's probably just because you're providing the services in some way.
Yeah, I mean,
that's not relevant for this structure.
Yeah, I mean, if we take, say, non-native English speakers, I mean, we would have access to language line and translators, etc., within the service. So we wouldn't necessarily set up a specific service, but if we felt that there was an emergent issue within a particular population, we might want to do something specific or different.
Yeah, I'm happy with that. Thank you very much.
Thanks, Martin. David?
Thank you, Hussein, and thank you for the paper. I have a general question, if I may, first, and then some specific questions on the data in the report. The general question is, given the focus on the financial health of the IJB, would we expect to see any mention of budgetary compliance from the team in this paper?
Well, we report to Amy in terms of our financial governance. The majority of funding that's come in relation to alcohol and drug partnerships has been ring-fenced or designated by the government directly for investment in alcohol and drug services and EDP provision. So we've been quite fortunate, but I suppose that's the priority that the government has currently given alcohol and drug related issues in the country currently. I don't know if Amy would concur or any of the other senior leadership team.
Yeah, that's right. Simon, we have that ring fence funding that comes from the government every year, and certainly that has been increased in the past based on additional funding for particular types of drugs which have been shown to be really beneficial, and we've built that into our financial plans Unfortunately, what we've seen with the ADP funding is that it probably hasn't increased at the level we would have liked, Simon. So we understand that, you know, it is a challenge that you have across your area in the same way that we do in other areas of the Health and Social Care Partnership.
I turn to Richie.
David has some more questions.
Yeah,
Hold on, sorry. Apologies, David. Carry on.
That's okay. I'm not sure if I'm satisfied by the answer to that question, that my first question about budget, and that goes back to what we were discussing in Amy's medium-term plan around all colleagues taking ownership of the financial situation that we're in and the future of that situation. So perhaps something we should think about in the future. May I go through some specific points in the paper?
Please do.
So on page 7, the partnership continues to prioritise drug-related deaths. Is the bullet point third bullet point down? Yet the drug-related deaths are increasing over time, and I wondered how our data compare to other IJBs. I'll stop there.
Yep. So I guess there's the work that we do to provide people with the right help and the right support at the right time, hopefully. The context of the substances that people use and the risks that they experience changes quite dramatically on a year-to-year basis. So currently there are very potent, harmful combinations of substances in the supply side, the black market in a sense, and in a sense that the risk has increased. So there is a changing pattern. There's current drug alert in Aberdeen, along with 7 other areas in Scotland that have seen a sort of increase in non-fatal overdoses, as well as other drug harms. So it's not a static risk, and it's not a static picture. However, I think we do reasonably well in Aberdeen in that we are not an outlier in terms of drug deaths within our population, although the high number is obviously tragic and very upsetting for everybody involved. But we are not an outlier in terms of the rate of substance use harm.
David?
So my question is, thank you for that. My question is, are drug-related deaths rising in other IJB areas covered by other IJBs across Scotland?
They tend to fluctuate on a year-to-year basis. We generally use a 5-year rolling average, obviously, to try and mitigate against that. Drug deaths have risen across Scotland significantly since 2017, and have to some extent almost plateaued. The drug death figures for 2024 will be published in August. So there are some areas where it's increased and then decreased quite rapidly, but overall across Scotland, they're a sort of maintained high level of harm in the community.
Okay, thank you. I'd like to move on to 4.13, theme 3, page 166 of the pack. Talks about service quality improvement, and I wondered if that's quite accurate. Is this describing delivery as usual rather than service improvement?
It's a mixture. I mean, there's always the challenge of maintaining and keeping services and operating as business as usual. I mean, it's a highly complex, challenging area of work, and obviously our staff are highly pressured within it. But the government programme, the medication assisted treatment programme, and the residential rehab increased provision programme are quite substantial pieces of work that have got specific standards There are 10 standards in relation to medication assisted treatment, which cover, as it says there, the same day access, trauma informed care, integration with other providers, etc. So it has caused us to, in a good way, change and develop what we're doing and respond to the population's needs in different ways. So I think it's a combination of ensuring that our services are effective and efficient and that staff are supported, but also achieving the specific standards required by the Scottish Government of Scotland.
Thank you. I don't doubt the difficulty of the area, for sure. In 4.15, the specific improvement work, it talks about in the first bullet point, increase uptake of drug treatment by 10% annually by 2021. That's 4 years ago. I just wondered if you could put that into some context for me. My note to myself is that it lacks ambition.
So that was one of our outcome improvement pieces of work with community planning. So that's part of the overall 3-year programme that we were working on at the time. We are resetting our specific improvements and outcomes for community planning currently, and that was a particular piece of work that we did to try and engage in locality areas, and we now maintain that and have redesigned services to reach out to particular communities. We have different projects. We have delivery systems and staff who provide a sort of crisis response to support people. So yes, it's historic. It was a particular time-bound piece of work to make an improvement, which has now become business as usual. But I would agree that I think going forward, and particularly with the focus in the city on health equity and prevention, that's an area that we'd want to try and increase and progress more rapidly.
Okay, thank you. I'll leave it there. Thanks for all your work on that.
Thank you.
Okay, thanks, David. I'm going to Richie and I'm going to John. So Richie.
Yeah. Thanks again for the paper. There are lots of really good practical examples of activity that's underway across the city. I did have a similar point to David about the budget or resources overall, but I think that's been covered. And the reason, I guess, just to tease out the basis of earlier discussion today was if there was something that was beginning to become pressured in terms of the area or the stations that be taken about priorities, for example, whether that might start to impact on the IGB as an early warning system, I guess, around just being aware of that if there are any implications that might just emerge for us in that setting. So that's just, I guess, contextualise that a bit. But I appreciate that might be for future. And I know you're reporting through Amy, as you say, just in terms of the financial performance. My other point, I guess, is just around IGB more generally. I think it's implied kind of heavily through the paper around the connection between the activity of the service and the work of the IGB. I just wondered if you wanted to say anything more, just in summary terms, around how this does complement, reinforce the role of the IGB, just again for the benefit of us today.
Yeah, absolutely. So there are some aspects of the work that the ADP does which are related to, I guess, the whole population and health in general and wellbeing in general. So certainly one of the pieces of work that we've started doing is looking at how we take both system approaches to things like alcohol consumption, where yes, there'll be some people who drink to a very severe dependent level, but there are also people, you know, the majority of our population consume just a little bit too much alcohol, and that has a big impact on our health and social services. So in looking forward with the health and social care strategic plan, which has some specific alcohol and drug related targets in it, and with community planning, we want to try and influence our partners to look at that whole system approach to trying to reduce harm, and particularly in some of the more deprived areas where the combination of, for example, alcohol consumption, smoking, obesity, etc., can be a cumulative multifactorial problem. So just responding to an alcohol issue as a standalone topic or intervention probably doesn't do enough for the community where there are sort of these multiple factors that impact on people. So I'm not sure if that's answering your question, but I think it's good having an ADP that gives a focus to the topic because it's a really important topic. But I guess what we also need to do as an ADP is not just think that we can deliver it all on our own. We need to work with partners across the whole system and every opportunity to try and reduce harm.
Thanks, Richie. John.
Yeah, thanks. I just had a question on sort of paragraph 412 on page 165, where you talk about a new data system tracking overdoses and etc., and enabling more responsive interventions. I just wondered if you could expand on what's going on there, how it works, and I'm assuming that more responsive means more effective.
Yeah, so I guess there's quite a few things that we've started doing over the last couple of years. So we now have a system where all non-fatal overdoses are reported, all drug deaths are reported, all our crisis response and outreach services are noted. And we can look at that in terms of postcode, so we can see if there are particular issues in a particular area of the city. So, for example, recently during the current drug alert, I won't use the postcode area, but we did see that one postcode area had quite a number of drug-related deaths, but quite a low ambulance call-out rate for people seeking help. So using that non-fatal overdose information, the drug death information, we managed to do a piece of work in that particular postcode area. Not sure if it's had an impact yet, but we're able to use the data in quite an agile way to reach out to particular communities. And we can also look at the rate of naloxone distribution in particular communities, etc. So we are getting a bit more sophisticated in terms of responding to some of the acute harm in relation to that. But we're also using the data to look at themes and trends in terms of the place where people are living, but also the demographics in terms of age, people who live alone, women or younger people, older people, etc. So again, getting a little bit more tactical in terms of how we do that. And that's a combination of learning the themes from the unfortunate drug and alcohol deaths, but also looking at the information that we can gather. But it's not a bespoke system or anything like that. That's sort of, it's still quite a manual piece of work, but we're able to use, you know, the tools, digital tools to help us do that.
Thanks.
Thanks, John. Any other questions? Hearing none. In that case, can I move to recommendations on page 159 and 160? We're asked to note the contents of the report, and we're asked to note the completed Scottish Government survey at Appendix A. Are we happy to agree?
Yep.
Thank you. Agenda item 9.1, shifting the balance of care, a community-focused approach to deliver frailty and specialist rehabilitation services within the Aberdeen City Health and Social Care Partnership, pages 343, 394. I invite Julie and or Sarah to speak to this if you wish.
Thanks, Chair. It's Julie Warner, the Chief Nurse, who will present this paper and kind of firstly address a couple of errors and typos we just need to add to the paper. So the first one is on page 344. Recommendation E should say make the direction as at Appendix 2 and instructs the Chief Officer to issue the direction to NHS Grampian and Aberdeen City Council is the bit that's missed there. And then we have another couple of dates just at the end that we also need amended. Page 393 and 394. 393 should be the date of the direction. The IGB meeting should say 23/8/23 and not 25. And then the last one is the timescale on page 394, which should say timescale direction end date should be 31/3/26. Thank you.
Okay. Are there any questions for Julie? Yes.
Thank you, Chair. I'd like to ask about Rosewell House. There is mention in the paper, significant detail about the benefits of moving towards community care and reducing, shall we say, the use of Rosewell House. Is there a view about the future of Rosewell House? Is that being considered? That's not really clear within the papers.
So that's certainly something we are looking at and looking at our options. If there is agreement today that we can, if our recommendations are accepted, we are certainly going to look at other options and those welcome.
Well, so those future options for Rosewell House would presumably fit into the strategic plan and help with our fiscal position. So there's ongoing strategic consideration about the future, long-term future of Rosewell House, perhaps as part of the asset review that's underway. Yeah.
I think Claire's going to come in there, Martin. Thank you.
Yes, thank you. So one of the things we're going to do is an options paper in we recognise that, you know, through the modernisation of social care, what does Rosewell House need to look like moving forward? So there will be an options paper undertaken looking at a variety of options with pros and cons of each of them for the future as we start to reduce down Rosewell.
Okay, thank you. And time-wise, we're okay with deadlines and so forth, because there will be savings that will be considered as part of this review. So we're okay with the timeline. Yeah, thanks. Thank you.
Thanks, Martin. Down to Jim, please, online.
Yeah, there's a brief reference in the paper to the workforce implications. I was just wondering if there was any more detail on that in terms of, for example, how many staff might be affected, what the arrangements are to manage the transfer into the community settings.
Yeah, so we will go through an organisational change process with our staff. Very aware that there are no redundancies within our NHS campaign policies. So we would certainly ensure that staff have jobs and there will be jobs available in a new model, as well as existing roles that we have in our service.
Thank you.
Thank you very much, Chair. No, it's no surprise that NHS Grampian had a critical incident back in November of last year when Rosewell House was then stood up as contingencies. Where do we see the impact on the flow coming with the significant reduction?
Yeah, and I think that's probably led to why we feel we need to change the model of delivery. We certainly have a large, as you alluded to, we've got that critical incident that occurred. We still continue to have non-standard bed spaces in use. I think if we can prevent people coming into hospital, reducing the need for long-term care and packages of care and delays, then our turnover should be more efficient. Therefore, we're very hopeful that will reduce impact on front door. I think while we go through this transition, we can't say we won't have some impact, but certainly in any bed reduction we've had to date, we've had a very minimal impact on the front door.
Okay, I think this is the whole thing about cross-system work, the impacts we'll have, and I think we have to really watch that very, very carefully. I think is all I'm saying. There's obviously that's built into your plan to have that.
Absolutely, and I think we would aim to phase reduce Rosewell, so we would be managing that impact and monitoring that as we phase, so we have that option of pausing, reflecting, and taking stock from there.
Thank you much, Chair. I think it's important that we highlight that as being a concern.
Yeah.
Thank you.
Thanks, Mark. David?
Thank you, Chair. Thank you for the paper. My question is follow on to Mark's, I think, really, and that is the plan, if I understand correctly, the plan is to gradually phase out this care home, the beds in the care home, and instead have care at home for individuals. And I wonder how, if we've a feeling of the effectiveness of the care at home model in terms of as a test case, let's say, are there test cases of preliminary studies of how effective the principle is likely to be? Sorry, if does that make sense?
Yeah, I think so. I'm hoping I can answer that. We've certainly had other health boards who have done very similar models, who have been successful in their delivery, and we are learning and adopting from them to ensure that we can replicate that and have the same successes.
Okay, that makes me feel more confident. Thanks very much. And then again, following on from Mark, so is NHS Grampian aware of this activity and the risk one? There's a risk of affecting the acute sector. Have NHS Grampian got a heads up on this?
Okay, so I'm gonna let Julie to answer, but I think Nicola and possibly Fiona might want to come in as well.
Okay. Yeah, we've certainly given our NHS colleagues the opportunity to consult on the paper, and they're very aware that this work is ongoing.
I'll just come in. So David, just to clarify, Rosewell's not a care home anymore. So and I don't know if that's what Nicola wanted to raise as well, but it's just to confirm that, so in 2023, we moved it to 2021, we moved it away from a care home, gosh. So it's just to let you know that that's, you know, it's a different model that we've been running there from since 2021. And just to confirm, NHS Grampian are aware they have got concerns as well, but we will be doing this in collaboration with our partners in NHS Grampian. And as Julie said to Mark, it's something that's looked at daily, is the data to understand what's the front door looking like. Is any of the changes that we're doing making that impact? And that will continue as we go through this process. And I think that's why we're very keen to do it as a phased reduction, while we build confidence in the model. And as Julie said, I mean, some of the providers that are already doing this in other partnerships have seen a significant reduction in people that have gone on, who would have traditionally just gone on and got care, but they have for that initial period of the wraparound support that the model we're looking to move to, and then actually a reduction of over 35% of people going on to need no care who had traditionally been getting care. So I think there's definitely an opportunity for that different model to really make a difference to people's lives. Thanks.
Right.
Thank you very much.
Was there anything, Nicola, that you wanted to add to that?
Thank you, Chair. No, I was just going to add on the statistics from Dundee Partnership, who had adopted the model of care at home. Of 140 people discharged between April 23 and July 24, 75% of them remained at home, and they had been referred for a care home in the first place. 36% of those needed no care at all. So I suppose it was just to kind of evidence that it does work when we try the care at home model. Thank you.
Dave, did you have any follow-up?
No, Chair, that's great. Thank you.
Okay.
Okay, I'm going to go to John and then I'll come to you, Mark. So, John.
It's kind of continuing on the same theme. So if the Dundee, sorry, I'll start that again. When I look at the paragraph on discharge to assess, where it's saying 36% of patients cared for were able to remain at home with no further packages of care. So my question is, what about the other 64%? So I'm assuming that in light of what you said about Dundee, some of them will need to go back into hospital, but also some of them can continue at home, but they will need further packages of care. So what flexibility have we got to put those packages of care in place quickly? That makes sense.
Claire?
Yes, for yourself, Chair. So one of the things, and it's been touched on, that a lot of our some of our delays, a lot of them are for long-term care, and some people are waiting for care at home. So we always say that a positive destination should not be coming out of hospital going into a care home. And that decision and assessment should not be made at home. The discharge to assess is getting people out of hospital when they're medically fit and getting them out and actually assessing them in the room. So some people will not require a care home. Some people will be enabled to have no care at all. Some people will remain at home, but with a care at home package, which would be slightly reduced or not the need for long-term care, which means they can remain at home. So one of the things that obviously our measures were going to be that are actually those that are in nursing home, the need for nursing care and long-term care will start to decrease if we can meet people's needs at home and keep them much longer.
No, I totally I totally support the approach. It's just that my question or concern is around if they do need some support.
Yeah, they do need.
How quickly can we put that support in place?
Yeah, and that's one of the things. So we have got our Granite Care Consortium, our main provider. We provide care at home. So working in collaboration, we're going to be working very closely between the discharge to assess whoever that provider is, because I appreciate we're now to tender, so we don't know that yet. There needs to be that streamlined process, and that is going to be really important for the step down of that assessment through discharge to assess through into that continuing care.
And I think just to add to that, that's where we need to make sure we've got really seamless community services. So we've got our hospital at home links very closely with that, so we can step up and down.
Yeah. And
we can seamlessly transition through all of these services, using tech, using everything we can to make that as seamless as possible and to prevent readmission.
I'm reassured by the word seamless.
We endeavour.
Thanks, John. Mark?
Thank you much. Going to page 358, regards to the time frame of this. We're talking about doing this by March 2026. Obviously, there's some contingencies that if things are not going to progress, but how confident are you on what I would see as a fairly tight timescale? I know we're in July 25, but March 26 will come around particularly quickly, and we've got a winter to go through as well as we know. So how confident are you in regards to that time frame?
So we're currently planning processes and making sure that when we do get a care provider, we are ready to go and we can step up really quickly into that model. Initially, I think we will be starting on a smaller scale to ensure that we can stop always evaluate as we go. But I am fairly assured we can do that time scale.
The Bayside model, the Dundee model, did they do that in that kind of time frame? They did. Okay, thank you.
Mark, Amanda, please.
Yeah, thanks. I like a lot of the reports in the today. It was easy to understand, so thanks very much for that. But I was sort of on about the new people that have to come out of hospital and then sort of have to get care. I'm glad that you are thinking about sort of doing that a bit more, because obviously they've been in hospital but they're actually not physically well isn't really a good thing. So I'm glad you're sort of thinking a bit more about that. So that's the thing. But I think the worry might be that because of our funding, we might take some people out too soon and put them in a home without the adequate support.
And I see Joy online. Is it on this point, Joy? Is it a question or?
Hi, it was just a comment on behalf of NHS Grampian about the Rosewell beds.
Yeah, please go ahead.
Yeah, thanks. So I'm Joy Miller. I'm one of the portfolio medical directors in the Musk portfolio, medicine non-scheduled care. It was just to say we do know about it, but we only found out about the most recent plans for closure of Rosewell beds after they'd already been approved at the chief executive level, and there are really quite significant concerns in the team, in the management team, on the acute side about how the impact is going to be managed. I think there's absolutely no concern about the general direction of the trajectory of modelling, looking after patients in their own homes. I think that's a good model, and we've seen really positive data from Tayside on that. But the Tayside team are very clear that their view is that we need at least double the number of acute beds in frailty in order to make that work. So Ward 102 is our main frailty ward at the moment, but their modelling would suggest that per head of population, we need at least double that footprint as inpatients, plus some medium-term downstream beds, preferably one for each health and social care partnership. And we have major concerns about how that will work with closure of Rosewell while that's in place. I've been on as medical director on call last night for ERI. This is June into July, and the hospital using every single contingency bed in place, and we still had ambulance stacking to people waiting 6 hours by 3 o'clock this morning in several ambulances at the front door. So the hospital is not coping, and it's not a service that's sustainable or that we would want delivered for our patients in the community. And I think I just want to raise concerns on behalf of the NHS Grampian team that I don't feel that the modelling that we've seen is thought through sufficiently or staffing sufficiently in place to be safe to make these changes at the moment. We almost need the opposite move in terms of patient bed space to facilitate these changes. I fully understand the financial envelope and the practices that are contingent upon that, but I just wanted to make that point on behalf of our team. Thanks.
Thanks, Joy, and thanks very much for saying that. I think it's really important that we do hear from our partners and our colleagues on the front line. I'm just going to take Fiona in at this point. I'll come back to Amanda if you have any follow-up, but I'll take Fiona.
Yeah, so just to clarify, Joy, this paper today is about the 30 open beds that are the intermediate care beds. What you were referring to, that was a decision that was made at Chief Exec team, is about NHS Grampian's beds that are currently in Rosewell, which are surge beds. So we're talking about two different things. So just want to clarify that point. So, and I am very aware of the concerns of NHS Grampian, and we're having that conversations, but I think we have to do something different. We know that the model is not working that we currently have. And I think that's the thing. So we have had conversations with the National Clinical Lead for Discharge Without Delay, and he is also supportive of the 30 intermediate care beds in Rosewell closing to enable us to release that capacity and finance to do a different model. And I think, we know that, and I think that's why we want to do it now, so we can get it up and running, hopefully as quickly as we can, so we have the new model in place for winter, so that we ensure that we mitigate the risk against that flow and pressures in the service. Thank you.
And I see, before I come back, I see Jamie's got his hand up as well. Jamie, did you want to come in?
Yeah, it was just on Joy's point. We constantly hear from our colleagues in the front line, from a partnership point of view, the concerns that they have about the current model within NHS Grampian. And I sit on the corridor care delegation group, and the concerns that we have. And when we started off on +1, we're now at +5 risk assessment, and it's just become the norm on a daily basis. Staff expect to come into work and find patients in a corridor. Nobody wants to deliver that type of care. We aim for a gold standard, but there's no way we're even at silver at the moment. Across all our specialties, mental health, maternity, and the acute and elderly sector. So we need to do something rather rapidly to try and rectify that. And also to release the pressure on staff. The moral injury of what's happening at the moment with stress and everything is having a huge impact. We're starting to see the moral injury of the COVID period coming to light now with the stress and all the changes that have been made. So yeah, we need to try and do something different rapidly.
Come back to you, Joy.
Yeah, thanks very much. Fiona, I do appreciate the modelling that's going on, and I think that's the right direction to go. But I just wanted to make the point, I'm not actually referring just to the surge beds in Rosewell. I think speaking with Sarah Alder, who's the clinical lead for frailty, I think her view is very much that we need every single bed that we've got plus double, and that would be Doug Loudon's view. He's the clinical lead of the service in Tayside, who do have a very effective model, as you know, with discharge to assess and all the rest of things up and running. So I do mean every bed that we've got, that whether it's belonging to NHS Grampian or belonging to Health and Social Care Partnerships or the IGB.
Yeah, Julie.
Can I just add, I think it's really difficult. So I don't disagree that perhaps we do need more beds in our system. I don't agree that they might be acute beds. I think we may well need more rehab beds. We may need more step down beds. I think the challenge we have is at the minute, we can't determine a true bed base while we have so many other delays, corridor care in our system. So I think until we have discharge to assess and our discharge without delay model in place, only then will we be able to identify a true bed base and what we need and ensure that that's turning over correctly.
Amanda, did you have a follow-up to your?
No, that's fine. Thanks for the
Thanks
answers.
very much. Thanks for the feedback on the papers as well. I think it's important that we realise that our lived experience partners are just as valued a part of the IGB, and it's good to hear your feedback that you're finding those papers easy to go through and helpful. And if you do have any feedback on what we can do, then by all means, please raise that. I'll come to Richard. Did you have a question as well?
Yeah, it's kind of it's an interesting and important conversation, and I guess I'm kind of feeling a bit conflicted in some ways around some of the points that we made. I think we're all agree the direction is right, and I know there's a complementary paper later that we can't get into just now around the service overall. I guess I'm going to change the question. I was going to ask it to this one, and I think it's around that transition, option appraisal and transition piece, and hearing the concerns in terms of so if the NHS staff alongside I think the right direction we want to go in. Is there a way of that kind of option appraisal and transitional phase to seek to accommodate that? No, I'm not. I don't know if there is an answer that will satisfy everybody bluntly, but is there a way in which the next stages, if this were to be today, then what might be the mechanism whereby that more explicit conversation collectively with colleagues that have a stake in this can be absorbed, and I guess just to make sure we collectively get to the right conclusion in this. So I'm not necessarily saying we don't want to take a decision today, but I guess if from today there's still some concerns, how are those potentially being addressed and mitigated, if you like, in terms of what we end up with?
And I think that's really key that we evaluate as we do that phasing. So if it is felt that actually in that initial stage we still have a lot of work to do and it's not working, I think we're keeping our NHS colleagues around the table in our discussions and reevaluate and progress that as we go. We certainly have those well available to us until the end of the financial year, so that is still an option.
Sorry, I was just to add on to that, to give you some assurance. I suppose one of the things is we need to accept a level of risk. I think if we keep doing the same, we're just going to get the same results all the time and the same delayed discharges. So this is a chance to do something completely different, and to mitigate the risks, we need to phase out slowly as we build up the resources in the community. And I think that is going to be key to phasing out early, but really building up resources and modernising, because if we just keep, as I say, doing the same, we're going to be talking about delayed discharge. We've been talking about it for years, and it seems to talk about it all the time, and it's going to keep on going. And I think this is an ideal chance, but phasing it out, mitigating the risks. I think there is some nervousness around it, but I think we absolutely have to go for this, give it the focus it deserves, and build up the resources in the community whilst phasing out that very traditional model that we've got. And we will obviously look at what is community rehab, what would rehab beds, where could they be in the community, and just looking at all our options for different models.
And I think the options appraisal gives us an opportunity to consider what other gaps do we have that those well could be used for. That will also help with some of those delays and some of the pressures we have in our system.
Into David and then Mark. So David.
Thank you, Chair. I guess I'm trying to come up with a solution as well, and what I was going to propose is, can we maintain all of the beds while we scale up community care, and then start to phase out the beds? I guess the answer is that there's not many for that, but that would be my proposal. Is that an option?
So at the current time, David, if I may come in, Chair, it wouldn't, because we wouldn't have the money to do both. So we would need to come up with other budget savings if that was the proposal for the IGB, and we would be looking to your support for that, because we will have to make very difficult decisions if that's what was agreed today, because we have not got that in the budget to have. We couldn't double run at the minute. We have got a bid into the Scottish Government. However, I think there is we're still waiting to hear from that bit, whether we've been successful in getting any additional funding from them. We don't know when we're going to get that letter because of the escalation of NHS Grampian, and they're doing the diagnostic review. So that might not give us the money in the time when we need to do it. And if we did, we wouldn't get the money that we're looking for to do this successfully. I wouldn't expect, because I think the government got much more higher bids in from every health board in Scotland. So I think that would be difficult. So I think to do that, we would need to come up with significantly different saving plans.
Okay, so you asked for my support in that, and I can affirm that I would provide that support. What I'm not sure I can do is support this paper as it stands at present. Thank you.
Go to Mark and then John.
Thanks so much. I think that was always going to be the answer, Fiona, but that is, and I understand David's point as well. And I think you're hearing some concerns now coming through the system here about, I'm going to go back to the time frame here. Okay, we've got recommendations here. We've got B that says that we should be withdrawing the services by the 31st of March 2026. But then the next recommendation is maybe no significant impact on flow within the hospital setting. So I think those two recommendations can be quite difficult to set, because if you get to closing it all by March and there has noted impacts coming through, how do we change that in certain respects? That's my only, that's one of my concerns.
So I completely understand. I would just like to give board some reassurance. So from a delayed discharge point of view, we have 3 in ERI, or we had 3 in ERI yesterday. So, the team worked really hard on our delayed discharges. So I think we're actually still a really high performing partnership in delayed discharges. I appreciate there's a Grampian picture, but if you look at Aberdeen City, we're still the 6th best health and social partnership in the country on our delayed discharges. And three have overtaken us, mainly because they've had additional money from the government. So I think we are still, the team are continually looking at the models that they're doing, the way that they're working to make sure that we're doing everything we can to ensure people are placed in the correct place. But I think Claire's going to come in.
No, I was just going to suggest through yourself, Chair, if we could have a short recess.
Yeah, so what I'm going to do, that was going to be my point, because we are running up to an adjournment anyway. So I'm going to take John's point, and then we will deal with it from there. John.
Yeah, I'm not sure I really want to ask this question, but I will anyway. I'm kind of swithering hearing different comments around the table, and I'm kind of persuaded one way and I'm persuaded the other way. And the question I was going to ask was, if, and I'm not saying we should, if we deferred a decision to the next meeting, what would the implications of that be? Sure. So I'm kind of, do we bite the bullet today? If we don't bite the bullet today, what does that mean? Yeah. What are the implications of a delay? Maybe that's a question that could be thought about in the short recess.
Yeah.
So we are coming up to the time for recess. I propose that we initially recess until 1:05 to give colleagues a chance to consider what we've heard, because we have heard a wide range of comments, and we will extend recess if need be until we can come up with a way of moving this forward, and I will seek guidance from colleagues on how we do that. But let's take our scheduled 10-minute break now anyway, and I promise I'll give you the full 10 minutes and possibly more than that.